Okay, and now we come to our last speaker, who's a change on our program. We're having Dr. Leanne Chapple, and Dr. Leanne is a postdoctoral researcher at the Royal Adelaide Hospital. She's a dietitian, and she's going to be talking to us about what's new in critical care nutrition.
All right, thank you. So obviously I'm a fill-in. You'll have noticed by now that I'm not Carol Hodges. Unfortunately, she had to pull out at the last minute, so I was asked 2 days ago to put together a presentation for today. So who am I? So I'm the PhD birth child of Marianne Chapman, Adam Dean, Darren Hyland and Lauren Williams, who's a dietitian from the Gold Coast. And since last year when I finished my PhD, I've been working on a postdoc research fellow for 2 days a week and then clinical dietitian at the RA 3 days. So 2 days ago, this is what my slides look like. Ironically, on Saturday, I was going through a walk through Morialta Falls, which if you haven't been there and for visitors, it's a nice little walk to see. And I was listening to this podcast. I don't know if anyone's heard of the SMAT podcast. They're very entertaining. And one of the things I took away from this is that in preparation for delivering the greatest presentation in the world, you should practice. And you should practice months before you do your presentation. So given the lead-in time, I'm hearing this presentation at the same time you are for the first time. The other thing I took away is not to use dot points in your slides, so hopefully I can at least achieve that. So the question that I want to sort of start with is, what do we want to achieve for our patients when we're looking at nutrition in research? So going from an ICU, this is not what we want in terms of recovery for our patients. We would prefer to have outcomes like these ones. We know that patients lose a lot of muscle when they're in ICU. So Zudem Puthakari has shown in 63 patients using ultrasound of the quadricep muscle over the first 10 days of ICU that they lose about 17% of their rectus femoris muscle. Selena Parry, who's a physio from Melbourne, has also shown in a smaller cohort that they lose about 30% of the rectus femoris and 14% of the vastus lateralis muscle. So it's a real problem. Some of my PhD work in a subset of traumatic brain injured patients also followed them a bit longer on, and you can see that they've had a significant decrease in the muscle layer thickness over that period. And this is a younger guy looking 3 months post-ICU. So they're really not back to their baseline even that long into their recovery. From Margaret Herridge's work, we also know that these patients have poor function 1 year, 5 years after being in ICU. So what might we do to sort of prevent this muscle wasting? So one thing, I guess, is to look at what other populations do things to improve their muscle function and their physical function, I guess. So sports dietetics is a great place to start. And one particular thing that they do really well is protein. So what do we know about protein in critical ill patients? To start with, there's a huge amount of opinion pieces, which, while are informed, aren't really the best thing to base your evidence practice on. There's also been an International Protein Summit, so it's obviously very important if they're already having summits about it. To note though, even though there was an Australian flag in that picture, there were no Australians on that international summit. And what do the guidelines say? So the American guidelines that were updated in 2016 recommend providing protein between 1.2 and 2 grams of actual body weight. To put that into perspective, for us, healthy population, about 0.75 to 0.8 is what we would normally recommend. It's important to know, though, that was based on a very low quality of evidence. As those guidelines show, only one guideline or one recommendation is actually based on a high quality of evidence, being a well-conducted randomised control trial. The European ESPEN guidelines that were announced and have just become available online in the last few weeks recommend around 1.3 grams of protein per kilogram per day, and to meet that progressively. The Canadians are a little bit more hesitant, and they say there's insufficient data to make a recommendation regarding the use of high protein diets for critically ill patients. So what actually is the evidence that these guidelines are based on, considering there's quite a variation in them? Actually, very little. So there has been a study by Matilda, who's just spent some postdoc time in Sydney, and she showed that a higher protein load actually did reduce mortality in ICU based on observational work. There was another observational study by Peter Wise that showed that the lowest mortality was in patients that met protein targets, but they're observational, and so they're a little bit difficult to base our practice on. This study by a Sydney dietitian, Susie Ferry, in 119 patients was a randomised control trial comparing 0.8 grams to 1.2 grams per kilogram, and they showed that higher protein could actually reduce muscle loss using ultrasound of the forearm and a trend towards improved hand grip strength. However, they use parenteral nutrition, which is slightly different to what we would normally do in our practice. Myself and an intensive care registrar published this paper last year that looked at any study in ICU that had a nutrition intervention and compared the protein dose that they actually received. It wasn't part of the targeted intervention, but as a subsequent outcome. And we showed that they didn't really have an effect on mortality as a group. And how many randomised control trials have been conducted to look at enteral protein dose? At the moment, none. And in fact, in a review of randomised control trials of nutrition interventions over a 10-year period, we found only one that actually looked at a functional outcome measure. So even though we think muscle wasting is important, we're really not even measuring that in our research to date. So what evidence do we need to generate in order to change practice? To do this, I want to ask the question, does increased protein delivery to critically ill patients improve ICU survival and recovery in those that do survive? And this got me thinking. I think the research we're doing at the Royal Adelaide Hospital at the moment is trying to answer 3 questions around this area. So the first one is, how is additional protein actually handled in the stomach if we feed more? Is that going to be absorbed correctly? And is that actually going to go into the muscle to be used to improve function? And can we feasibly deliver extra protein? It's all good and fine to say, yes, we need more protein, but can we actually do that day to day? So the first study to look at how protein is handled, our site uses scintigraphy, which is a gold standard for measuring gastric emptying. So this uses a small amount of radiation that's placed into the feed, and then the image here shows a camera that's placed over the patient's stomach, and that measures how long it takes the feed to empty out of the stomach. So we know from some of Marianne Chapman's work that in ICU patients, their gastric emptying is significantly delayed compared to a healthy population. But what we don't know is if different types of enteral formula can help reduce that. So does a protein dose of an enteral nutrition formula affect the rate of gastric emptying? So we're conducting a crossover randomised control trial that will be done in 40 ICU patients and 12 healthy subjects. The ICU patients we're going to try and divide into those that are feed tolerant versus those that are not feed tolerant based on their gastric residual volumes. We're going to provide a bolus of a high and a low protein dose, so it will be a crossover trial, and then measure gastric emptying over 4 days. I'd just like to acknowledge the 3 sites down the bottom that have provided us with some funding to purchase a new gastric emptying camera that we'll be using for this study. So this is our study protocol. We'll have a 4-hour fast, we provide the test meal, and then we measure gastric emptying over a 4-hour period and compare it between a high and a low feed. We're also looking at gut hormone levels and glucose absorption over that time. So once we know whether the body can actually handle the protein into the stomach, can that protein actually be absorbed into muscle? So we know from some of the work from our centre that glucose is impaired in terms of the absorption during critical illness. And Yasmin Ali Abdul-Ahmed has also shown that lipids are impaired in terms of their absorption in critical illness. But what about protein? So while we try and increase protein delivery during practice, what we don't know is if additional protein can actually be adequately absorbed and whether it's incorporated into muscle. So to start looking at this question, we've designed a study called the PACE study, which is looking at protein absorption in critical illness. And what we want to see is protein digestion, amino acid absorption, basal muscle protein fractional synthesis rates and the postprandial muscle protein fractional synthesis rates impaired in critical illness compared to in health. So to answer these questions, previously we've looked at using stable isotopes, but this technology, when you actually put some enteral nutrition into that, then that diffuses or deletes the amino acid pool. So we've gone to our Dutch colleagues who have actually infused amino acids into a cow, which gets incorporated into the milk, and then we can give that milk to the patients to actually measure how much is absorbed. So one of our colleagues, Imre in the picture there, came over to Australia last year. We didn't think about having a Dutch person from Amsterdam with 32 tins of white powder coming into the country would be an issue till it got to customs. So there was a bit of a delay there. So this study we're doing in 20 ICU and 10 healthy controls. What we do is we provide an amino acid infusion over the study period. We put a post-pyloric tube in through which we infuse the milk protein that's been infused with the amino acids. We take some blood samples from the arterial line, and then we're doing some muscle biopsies. So we use a biopsy technique called the Bergstrom needle here. So I was the first volunteer to actually train our doctors in the technique. I look much happier in the picture than what I felt on the inside. But it was nice to know what I was putting our volunteers and our patients through. We take a very small amount of muscle, it's about 55 milligrams. We weigh it and then send it back over to the Netherlands to be analysed, and they look at the tracer enrichment, so how much of that protein we feed actually gets into the muscle. And that tells us how much of the protein we feed goes into the muscle, how much is actually incorporated. And having an understanding of this means we can look at what strategies we can provide to actually improve patient outcomes in the long term. The final study is looking at how much of the protein we deliver is, how can we feasibly do that. So just a hands up, who's familiar with the Target trial? Okay, so for those that haven't been around, the Target study is the augmented versus routine approach to giving energy trial. So it was a 4,000 patient randomised control trial in mechanically ventilated adults who were receiving or expected to receive EN. They were divided into two, obviously received either a 1 kilocal per meal or a 1.5 kilocal per meal enteral feed. To answer the question, does augmentation of calorie delivery using an energy-dense enteral nutrition formula in mechanically ventilated patients increase 90-day survival compared to routine care? This was one of our fastest recruiting studies in Australia, so they actually had to bring the interim analysis forward because they would have finished the study by the time they actually got to doing their safety analysis. So it took 18 months to recruit those 4,000 patients. The results are going to be announced at the ESICM conference at the end of October, and hopefully to a nice medical journal soon, which one we don't know. So from that we're going on to do target protein. And I'd like to acknowledge the management committee there. So our question is, are we able to conduct a randomised double-blinded study in which administration of Formula X, which is a high protein formula, when compared to Formula Y, which represents standard care, will result in the delivery of more protein to enterally fed critically ill patients? And we're hoping that that Formula X will meet those recommendations in the international guidelines. So sorry, Emma, you'll hate this slide. What is standard care? So Emma Ridley up the back conducted, using the International Nutrition Survey, a subset of Australia and New Zealand practice, and showed that while we're prescribing 1.1 grams per kilogram per day, we're only delivering about 44% of that, so 0.6 grams. So that's what our standard care arm will hopefully receive. And then the high protein, using the guidelines, will be aiming between 1.2 and 2 grams per kilogram. So this is a 120 patient feasibility study at 8 sites across Australia and New Zealand, and has very similar inclusion criteria to Target because we know that that works. Our outcomes are to look at the separation in the protein dose between the two groups, feasibility outcomes, and also some clinical outcomes to hopefully guide us in what we do for a phase 3 trial being target protein long term. So these are our sites. Myself and Matthew Summers, a research dietitian from the RAL, the project managers. Adam Dean's the PI. And we're lucky enough to have support from a Royal Adelaide Hospital translation grant and industry sponsor for the feeds. And looking at the phase 3, hopefully in 2021, so keep an eye out for that. So where will all of this lead? Hopefully, we're going to have patients, rather than looking like this after ICU, looking like this. So this is Georgina. She celebrated her 100th birthday by going skydiving and went diving with the sharks the day after. Or maybe even more realistically, like this. Thank you.
Excellent. Thank you very much, Leanne. Do we have any questions for her? Yeah.
Thanks, Leanne. And yeah, well done on getting a presentation together so quickly and such a good presentation. You talked about, I guess, the end goal of improving functional outcomes and your study design. I was just wanting to see if you could elaborate a little bit more about how you're going to measure how patients' function might change over time and what would therefore be the comparators.
Yeah, sure. So in target protein, being a feasibility study, we are going to do some sub-studies to that where we have some ultrasound muscle changes. So for the sites that are willing to participate, we'll be looking at that. We'll also follow up with 3-month EQ5D5L hip function. For target, I did a sub-study looking at hand grip strength and walk tests, and getting patients back is very difficult, and I think that's the difficulty with looking at function, is how do we actually assess it in a big trial where it's so time-consuming and expensive to do those measures. So I think that's something we're grappling with, and would have been lovely to see Carol talk about that, because it's something that I know that she has focused on, and yeah, I think we've got a long way to go to finding a good outcome to measure that. All right, I think that's it. Thank you.
Thank you.
All right, well, can we all please just thank all 4 of our speakers this afternoon. I think it's been a really interesting update and some interesting considerations for trials. Thank you.